Atul Gawande, welcome to the podcast.
Delighted to be here.
Well, I'm delighted that you're on. I've been reading you for a very long time in your books and in the New Yorker and elsewhere. Um, One of the things that I think you've done for the American public is to take people inside what can seem like a little bit of a black box, the medical profession, the way hospitals work, to show, what determines when something goes well, when something goes badly, how some of these things function. Uh, you know, Before we get into some of the details of this, so what motivated you to do that? When, in your career, as a medical professional, did you think, hey, actually, there's things that are important to share with the public here?
Well, it's hard for me to put my finger on it. I come to medical school after having served on the Hill, doing health policy had a stint doing that. I'd grown up in rural Ohio, the son of two, my sister and I were the children of two immigrant Indian doctors for a rural community, and they were very active in being part of the community. I always grew up seeing medicine not just through the lens of the clinician, but also through the lens of, my parents knew everybody they took care of in a local community. So you see medicine through the community. And I came to practicing medicine out of also trying to see it as a citizen, when you're working on the Hill and you're thinking about it from the perspective of taxpayers and everybody else. And then I think one more thing really made a difference, which is in my fifth day of, July 5 of my residency, my son was born and had a cardiac issue that kept him in the hospital for a month. And I was physically going back and forth between being a brand new intern, trying to convince people to let me, join their operation to learn on them, to being on the other side as a dad with a child with a very serious congenital heart defect that would require surgery and needing to navigate it from that point of view. And so by the time I got the opportunity to be writing about these things, I think I'd already absorbed needing to see it from a lot of different perspectives and not accepting that it would be okay to pretend we're infallible, that everything, leave it to us, the experts. And that was changing in the modern world anyway.
Yeah, one of the things that I really appreciate about those early books is that I feel like there's two rather different views of medicine, both of which are perhaps a little bit one-dimensional, right? So one is of medicine as this perfect, exact science. We have exactly the rules to apply. Doctors are omniscient, and they have understood the capital S science, and so any questioning of them, any uncertainty, any room for ambiguity doesn't really exist, right? Now, I think there's also a view on the other side, which is that this is actually just a complete art, and we should just trust doctors that they're the most skilled craftsmen who have engaged in this profession for a very long time, and that their judgment is superior not because there's sort of one very clear way of doing it, but just because they have this superior experience, knowledge, and virtue, and so therefore we should kind of defer to them. And it seems to me that you're articulating something rather subtle, which is in the middle between those two extremes, because you emphasize how much uncertainty and ambiguity there is. But in something like the Checklist Manifesto, you also say this view where doctors are these sort of consummate professionals, and it's their judgment and the practice of this craft that is superior is also wrong. Actually, in some circumstances, we should really give them these very strict guidelines and saying, even if you've done this operation 100 damn times, you have to tick each checklist off. So tell us a little bit about sort of where this in-between space lies.
Yeah, I mean, there's you hit the nail on the head. I'd almost characterize it that there's the view of doctors as heroes, which has the two extremes you describe, right? As craftsmen and as scientists knowing everything. And then there's the view of doctors as villains, right? Corrupt, not just unknowing, but in the business of medicine. And there was then my experience of being a young surgery resident trying to navigate, how do I learn to do this thing? And its incredible complexities, the way things go wrong. One of my very first articles for The New Yorker was about making a terrible mistake that nearly killed a patient. And we were navigating at that point the recognition that there was a study I got to be part of that encapsulated for me. We looked at 15,000 patients admitted to hospitals in 2 states, Utah and Colorado, and asked the question, when people have a bad outcome, when they die or leave the hospital with a serious disability, is that because the knowledge exists and we failed to apply it correctly? Mm-hmm. Or is it because we're ignorant of the knowledge? And what was striking was 2/3 of the time, the knowledge existed and we failed to apply it correctly. Yes. And that struck me as a incredible generational transformation. For millennia, human beings did not understand what was happening in our bodies, what were the diseases and conditions, let alone what to do about them. And that was as early as the 1950s. We mostly did not have solutions for most problems. By the time I'm in training, we have solutions, but we're not executing on them correctly. And that can inspire outrage, malpractice lawsuits, regulations, all of those things. A lot of the way medicine dealt with it was by training you more and more and more and more, as if you could jam all of this into your head and know everything and be omniscient. And what was clear is other industries dealing with high risk were adopting a commitment to systems that made it easier for people to do the right thing and harder to do the wrong thing. And we had not embraced that. My book, The Checklist Manifesto, was about navigating coming out of residency and starting to create some basic systems that became a kind of checklist in the operating room. And it wasn't a checklist like, here are the 19 steps to every operation you have to take. It was, here are the 19 things in every operation the team needs to be able to communicate about in order to make sure that you're prepared for whatever comes, that you're able to, recognize what are the special issues of this patient, what are the goals we have today, and work together and be a better team at moving together. And that is recognizing the system is all of us coming together. And it cut the death rate 47% in 8 cities in our original study, and then ultimately scaled around the world. That's a longer story of how do you get these things to move all the way around the world. But
tell us about the actual difference. Tell us about the actual differences in that approach. You're right that just being trained more and more and more to do the same thing is not going to accomplish perfect results. I mean, I spent much of my life writing for many years, and every now and again I still misspell a word stupidly, right? Like we're all going to screw up, even at things at which we're very, very skilled some of the time. At the same time, as you're saying, a lot of the abilities of a very skilled surgeon is that they may face a patient that has a condition that's slightly different from anything they've done before, right? They may discover a complication in the process of surgery that they didn't expect. So if you had what the name of that title implies, which is a really rigid checklist where it's just step 1, step 2, step 3, that's the fast path to failure. That sounds a little bit like the technology we had before Google Maps. I discussed this in a different context on a recent podcast, which is MapQuest, right? Great if you follow all of the 19 instructions, but if you miss one turn, then suddenly you're without a plan, right? So what does it look like to have a system that avoids these avoidable errors, but without giving you the kind of rigidity of action where one complication that wasn't anticipated just leaves you kind of lost?
Well, on this 19-item checklist, there are 3 pause points. You pause right before the patient's put to sleep, right before the incision, and then right before you leave the room. And at each step, there are what I've sometimes called dumb checks, right? Do you have the correct patient? Are you operating on the right side of the body? Did you give an antibiotic, if you're giving an antibiotic, in the 60-minute window when it works maximally? If you have fluid that's needed or blood, is it available in the room? So those are the kind of like very rote, just do it, dumb stuff. Most of the power of it, though, comes from these additional steps that you take for the people in the room to communicate that you would think happens every time, but doesn't. Most teams come together at the beginning of the day and they're entirely new. There's someone new on the team. There's, it's an assembled team. And so you start by asking people to simply name your names, like say your name, what's your role, and you go around and do that. And it does a couple of things. Probably the most important thing is it activates you to have heard your name in the room. Just like in a meeting, it gives you permission to speak again, so that when you have a concern later, you feel you have the voice to raise it up. Another part of it is that you discuss the plan and the person who's on the table. What are the key issues for this person? What's the equipment that we require? Is it ready? Does anybody have any concerns, including the patient themselves? And then again, before you leave the room, what's the plan for the next 24 hours? And do we all agree on it? And do we have our next action steps? And it's amazing.
And just to understand, before that, it may have been the case that the surgeon themselves, of course, has some idea of this. They know what operation they're doing, etc. But perhaps other members of the team didn't, and so therefore they weren't paying attention to warning signs of something going wrong. Or sort of tell us about how it's a change from what was the case before, and therefore what this kind of meeting accomplishes.
Yeah, I mean, when we designed it, and this was with the World Health Organization, when we were tackling how do we reduce complications in surgical care, we brought a Boeing safety engineer in. And in cockpits, in airline crashes, failures of communication that occur are often because someone doesn't speak up, that has information that should be known, or doubts or concerns, seeing things that aren't seen. And so, yes, the surgeon may have a plan in their head, but the anesthesiologist may know more about the medical issues of the patient that you should be aware of, that, they were on a blood thinner that was just stopped a day ago, that they have a history of XYZ condition that, you need to be reminded that might not be foremost in the surgeon's head or the nurse's head or others. And the nursing team may know about issues the patient may be having. They have a bad back today. They told me about XYZ. So everybody has a piece of a puzzle for making it come out with a better outcome, and they're not voicing it. They're not bringing it forward.
Well, I'm going to ask a question that seems out of left field, but that you're practically forcing, at least for anybody who's watched the latest season of A Rehearsal with Nathan Fielder, in which he goes to these elaborate lengths to suggest that really what's at issue in a lot of plane crashes is that the co-pilot perhaps is too intimidated to raise their concerns about a course of action of a pilot. And the way you're talking, it's nearly sounding, I don't know what you feel about plane crashes, but as though you're quite convinced that that is actually a very plausible theory, at least as it applies to medicine. But often perhaps there's somebody in the room who knows something that would be able to avoid those complications. And perhaps part of what's going on is a power dynamic where, if you don't feel empowered to speak up, you may sort of keep that concern to yourself in a way that has adverse consequences.
Yeah, this is probably the hardest part about implementing the checklist was a change in the culture of the operating room, because the highest value of the operating room used to be the autonomy of the surgeon. The surgeon was the fighter pilot, that we decide everything that happens, and you call it an operating theater in many countries. It's the stage onto which the surgeon steps up, and everybody is expected to be working for the surgeon. when in fact what we needed to do was to move away from the fighter pilot and more towards the pit crew, that we're all here in service of a goal together. All of our voices matter. We all have something to contribute and to say, and that one of the key measures of whether the checklist is being used well is whether you hear everybody's voice speak up to convey at critical moments in those pause points what the concerns and needs are and what you understand the situation to be. And we've shown, as we deployed it in South Carolina, for example, that every percentage increase in every 1 point increase on a 5-point scale in the level of teamwork, of respect, and of willingness to speak up translates to another reduction in mortality.
So in other words, Dr. House is a terrible guide to how to practice good medicine.
100%.
What are the cultural reservations you encountered here? I mean, one of them presumably is some of your esteemed colleagues saying, no, I am the fighter pilot, right? I am the most important person in the room, and I don't want to hear, the nurse speaking up, right? Another one that I have present in my mind is perhaps about some of this status of a doctor as the kind of craftsman who really knows best and who shouldn't be constrained by artificial scaffolding like the checklist. I know this because I have a friend who's a French doctor who wanted to get the checklist manifesto translated into French, and he has very good English. He wanted to do this. And I don't know if the book now has a French edition or not. This was, perhaps 10 years ago. But he had great difficulty getting it published because the response from a lot of French doctors was, we know what we're doing. Why on earth do we have to follow a checklist? This seems like a terrible American mechanistic view of the world. It doesn't comport with how we think about practicing medicine.
Yeah, it's an interesting cultural thing. Not between the French and the U.S., but between among surgeons. We surveyed surgeons, and their broad response was 70 to 80% would accept it, but 20 to 30% thought it was a waste of time. They didn't need it. It didn't matter. And that it's just another layer of bureaucracy. However, when you ask them, if you're having an operation, would you want the surgeon to use it? And 94% said yes. We all have a Lake Wobegon effect. We all believe we're above average. You wouldn't be a surgeon if you didn't have confidence in yourself. And, the difference between in general, for inpatient surgery, the mortality rate is around 1%. Cutting the mortality rate by half, as the studies showed, is a 0.5% reduction in your mortality. In other words, you're going to 0.5%. You can't feel the difference day to day between performing with a 1% mortality rate or 1% error rate and a 0.5% error rate. So, it isn't until you've had, and as time went on, virtually everybody ends up having an error, a serious error that's caught by using the checklist, and it makes you a believer over time. But that entry point, getting people to try it, believe in it, not turn it into a paper documentation effort, is crucial. And also making sure, they can easily become captured by bureaucracy. I've seen places that the 19-item checklist becomes an 80-item checklist. And then, someone has imposed it and put all kinds of steps in it that have made it harder to turn on your brain, harder to execute in the operating room. And that's why it's so crucial for the people there to be part of the design of it.
I think this is a really interesting point, right? But we are in general very good and professionalized at these operations. I mean, it's incredible that we're at a time when 99 out of 100 times we undertake these complicated medical procedures and the patient ends up being safe. But as a result, the difference between a lousy surgeon and a great surgeon is not 99 out of 100 cases. It's the one edge case. how do you go when you are objectively very good at this, right? 99 out of 100 times you fix some medical problem and the patient walks out of the operating room, perhaps not that very moment, alive and hopefully well. But you could actually do better. How do you get yourself to that higher level of performance beyond just avoiding errors through something like a checklist? I know you've written, for example, about yourself, when you were a very distinguished surgeon with a very good record, using a coach in order to get better at what you're doing, and what's the lesson from that for people within and outside the medical field?
Yeah, first of all, the error rate or the complication rate, not even error rate, will be higher than 1%. So we were talking about the death rate. So some of our operations might be 20 or 30% complication rates. And you have also around that some wide distribution. Some people will have 2 or 3 times lower rates of complications than others. A checklist helps lift your bottom end of performance, but I got very interested in coaching after really trying to understand how we train in some professions and not in others. I remember going, I'm a tennis player, and I remember having, a former college player paying them, $100 for an hour to go over my serve, and realizing that in the culture of sports, the number one player in the world, Carlos Alcaraz, Yannick Sinner, they have coaches at every step along the way. And by contrast, most professions...
a tennis player at the top of their game is not going to say, I'm a consummate professional, I'm at the top of my game, why on earth do I need somebody to give me advice? Whereas, that is an instinct
surgeons,
that many
lawyers,
people in other kind of professions are likely to have, right?
Yeah, most professions, surgeons, lawyers, musicians, do not have coaches. They get their years of practice and experience, their 10,000 hours, and then you're launched into the world, and the expectation is you are the way, you are the master of your own improvement. You are the best way to make that happen. And I remember I was writing for the New Yorker. I was interested in the subject. You got an excuse to call people up, and I called up Itzhak Perlman, the greatest violinist of his generation. And I said, why don't violinists have coaches? And he said, I don't know, but I always had a coach. He married a fellow concert-level violinist from Juilliard, his wife, Topi, and she would follow him, observe his performance, and give him feedback. Here's what you're doing well. Here's what you're not doing well. Here's what I noticed. You're a little wooden in this part. What do you think? And engage in that way. And so that led me to say, you know what? So I was at mid-career. I had my complication rates had sort of plateaued. I had been steadily improving, and I had sort of hit a wall. I'd done more than 1,000 of the operations that I did, and it didn't feel like there was any more room to go. And I said, let me bring one of my former professors in to come observe me. And he stood and watched, and I thought it went great. And we went back to the surgeon's lounge, and he had 20 minutes of notes to go over with me. Did you notice the light had swung out of the wound, and for 30 minutes you didn't have adequate light? Did you notice that the anesthesiologist was having trouble with the blood pressure during part of that time, but never told you what was going on? And so we worked together, and periodically he'd come in and observe and coach. And it was the difference between teaching and coaching is that the coach has an external view of your reality, is observing you, or they have data about how you're performing, and they make you face your external reality rather than what you think is your internal reality. And we have blind spots. We all have blind spots. And so, we have now introduced that in Harvard hospitals with our malpractice insurer offering a 10% discount to surgeons for taking on a coach or learning to coach others. And many of our departments have started training everybody in how to do coaching, because it's another change in culture and mindset, a growth mindset and a humility mindset that you bring to what you're doing.
And there's obviously a little bit of a collective action problem there where, look, you were a really good doctor with a lot of prominence, and you were writing about this in the New Yorker. And so for you to say, hey, I'm taking on a coach, is not embarrassing, right? But for somebody who perhaps is insecure about, I'm in the middle of a pack, or perhaps I'm a little bit below the middle, and if I suddenly take on a coach, is that a way of signaling that I don't trust myself, that I think I'm doing something wrong? That's going to be a big inhibition to people going down that path if it's normalized, right? Why am I doing this? Because that's part of what consummate professionals in our field do. Or even, why am I doing that? Well, because I get 10% off my malpractice insurance, right? That makes it a lot easier for people to take that step.
Really crucial. Many of the chairs of surgery that I've spoken to who've instituted it report that their quickest to jump in and do it are their best performers. That they are the most interested in hearing and have the most confidence about taking on a coach. Many people react by saying, that's just for beginners, that's for the new surgeons, that's not for me. But they're able to win people over by creating it as a norm, except for their bottom performers, who are often feel the most exposed because they have issues that are exposed by entering their operating room. And in many ways, it makes it easier for the surgeons, the chiefs, to deal with the low performers, because now you have a pathway into those operating rooms where you don't really have the line of sight into what's happening, even though as a surgical chief, you're responsible for the quality of your teams.
That's fascinating. And I think it transposes to other fields as well, that people at the top of their field often, A, are very good because they have that self-critical mindset and they always want to improve and so on. And B, just have a self-confidence to say, sure, I'm happy for somebody to observe me work, and if they point out some way that I can improve, all the better. Whereas it's people who already are insecure, who perhaps are lying to themselves, are telling themselves, I'm great, but they somehow have doubt and they realize perhaps it's not the case, who really worry about what if somebody observes me and I do something embarrassing, or they catch me doing something that exposes the fact that I'm actually not that good. So that makes a lot of sense to me psychologically. We're at a moment in which medicine is more politicized than it has been in our living memory, probably. Part of that is the pandemic and the way that played out. Part of it is RFK Jr. being the Secretary of Health and Human Services. How do you message the realities of medicine, where in the descriptions, including in your early books, there is often ambiguity, there is often uncertainty about what to do. Better outcomes depend on these systems, but those aren't fail-proof either. And so, humility is the right thing for the medical field. And at the same time, it's absolutely clear that at scale, medicine, delivers incredible outcomes for people, that we have extended the human lifespan in an astonishing way over the course of the 20th century, that the ability to get good medical care is very predictive of longer life and a better life. How is there a way for us culturally to hold those two truths in our heads at the same time, especially in a moment that's increasingly polarized?
You've asked a lot in that question. Let me start by saying, look, doubt and concern about medicine is not new. People, if anything, people have more confidence in medicine than they did, in the 19th century, when you would go to doctors and you would be bled, or you would be subject to treatments that often left people worse off rather than better off. And, today we're in a space where between public health and what medicine's been able to do, we've essentially doubled the human lifespan. And people spend about half their life dealing with a chronic illness now. After age 40 or 50, most people have one or more to navigate, and you have people to navigate that with. The further difficulty is the most challenging debates are around the parts of medicine where what we're doing is invisible. It might be a vaccination, it might be a medication. It does not have an immediate effect. Maybe I'm helping prevent an infectious disease or address high blood pressure, which isn't going to kill you for 20 years. And then persuade people that a sacrifice now for an invisible problem is going to produce a better outcome later. There's often, people who will mount attacks saying that the solutions coming forward are harmful. They're, when they're invisible, it can be difficult to try to get people to come on board. When Lister came up with a system of antisepsis that cut surgery's death rate by 80%, washing hands, using antiseptic solutions, surgeons did not believe it, believed he was trying to ruin the profession, and did not adopt for a couple of generations the basics of antiseptic treatment and behavior. And it was because you were asking them to use a antiseptic, which in his case was dilute carbolic acid. It was literally pain now for someone else's gain later. When you turn to, vaccines today, we've eliminated the diseases that killed huge numbers of children. We've cut child mortality by 75% since the 1960s. 40% of that gain has come from childhood vaccines. And now, maintaining that protection when the diseases don't frighten people anymore, but you can cast the vaccines as a villain, is always going to be a challenge. Now, the difference is in this moment is that the people that have been given power, people like RFK Jr., but also, President Trump himself, have defended and been the conveyors of the conspiracy theories. So where you normally have the leaders of our major medical institutions, the National Institutes of Health, the CDC, response to pandemics and so on, where they normally will be honestly trying to weigh the pros and cons of the evidence as it is, the, what's known and what's not known, and do it in a systematic way with scientists who've had a track record in the field, really trying to weigh it out. That is very different at this moment. We have, the CDC process, for example, involves doing a full review of the literature around any given topic that they weigh. Like there's a vote upcoming on whether they will remove hepatitis B vaccination for babies out of concern that there's no proof there is not harm. However, the second part of the process is that any change that's made is weighed against the evidence that it might cause harm. That second part has been removed as part of the CDC process. So now when they're weighing, should we remove hepatitis B vaccine, you will only hear, questions about, well, the evidence is incomplete. But we know we have reduced hepatitis, a killer of children in particular, by enormous amounts over the since we've instituted childhood vaccines for hepatitis. And the constant refrain of there's no proof of no harm is not being weighed with the consequence of removing such vaccines. And I think the way we navigate science is understanding no one scientist has a monopoly on knowledge and evidence. Science is a series of approximations. And the power that science has given us in the last century for public health and healthcare delivery has been a doubling of the human lifespan. That has occurred not because any one solution is perfect, but because we are continually evaluating, studying, driving evidence, testing our hypotheses, and approximating our way to better and better and better answers. And then, the counter is always these lines of argument that cherry picks evidence, comes up with people who may be scientists, but often don't have a track record really doing the work in the field and weighing the evidence carefully, and flies in the face of the larger community's assessment of where the evidence has led us.
So I'm sort of torn on the subject, right? I think it is absolutely clear that vaccines have saved myriad lives, vaccines in general, like that for measles and the COVID vaccine in particular. At the same time, I can understand people who looked at some of the actions of public health authorities during the pandemic, including some of the statements they made to the public, and who conclude, actually, this all seems rather less professional and rather more politicized than I imagined. So I just don't know whether to trust all of you. How are we, and I think about this in sort of different discussions today as well, right? I'm a professor at a university. I think that universities in the United States do incredible amounts of good. And I think that they provide a very good education to students. I also think that there are some genuine problems in universities. It was striking to see recently one of your colleagues, I believe both at Harvard and the New Yorker, Jill Lepore, say that she considered quitting academia and quitting her job at Harvard because she felt so constrained by some of the strictures of wokeness at the height of 2020. And so, it seems to me that we need to do a better job of both acknowledging where things go wrong and where we've screwed up, and defending the institution, right? And a lot of the time we're kind of put in this position where it feels like it's either one or the other, right? There's people who want to point out all of the mistakes and all of the problems within institutions like Harvard or Johns Hopkins, where I teach, or whatever, in order to dismantle those institutions. Or, there's people who want to defend those institutions, and the way they do that is to deny that there is any real problems. Is there a way of communicating that middle path about public health and about medicine more broadly?
Well, I feel in many ways that our earlier discussion about surgery is exactly that, right? That pretending surgeons are infallible, that we don't have complications, we don't have serious error rates, and it doesn't have damage that does, is insane. It does not serve us any good, and it does not build trust. No one is ever going to be 100% trusted. But that said, every time I'm amazed when, people see me, and they have barely got to know me and will, in the course of a half an hour discussion, entrust me to put them to sleep and open up their body and remove an organ or a cancer that they have. And that's because we have been able to demonstrate results in general. We've continually demonstrated improved results over time, even as we acknowledge we have high rates of error. We have areas that we don't have adequate knowledge and that are sometimes mistaken in serious ways. That there are that we can be prone to orthodoxy and, hold on too tight to some ideas and not tight enough to others. And the answer comes from being a profession that is constantly analyzing the mistakes, constantly striving for, aiming for perfection, but understanding you never achieve it. In the pandemic, there were, like a surgeon, teams needing to make, whether it's state level public health officials, federal officials, and so on, needing to make judgment calls that they were going to get wrong in the face of rapidly evolving information. Early on, we didn't move to masks fast enough, and I disagreed with CDC recommendations and wrote an article showing that there was, reviewing the evidence indicating that we should be instituting universal mask requirements in hospitals, that would stop COVID spreading in the hospital. And we adopted that and moved quickly, even, against CDC and WHO recommendations. And then it became the CDC and WHO recommendation to move in that direction. It was clearly, we did not get adequate effect from school closures, and we caused enormous damage that was not acknowledged and weighed to whether it was the mental health of children or their educational outcomes. And we're paying a price for that even now that people are justifiably angry about. That said, a world without the CDC, a world without, a world where I came back from, working at USAID where I led global health and saw the dismantling of an institution that saved 90 million lives over the last 20 years. And now it's resulting in hundreds of thousands of deaths already that have occurred from, dismantling by accusing it of being some kind of criminal enterprise, a money laundering operation, never accomplished anything of any significance, even as it was playing a pivotal role in controlling HIV and TB and reducing child mortality. That is a recipe for our own self-destruction.
Obviously, this is a moment in which public health and science is under attack in the United States. I think for people who are outside of the field, it's hard to evaluate how big and how serious the damage is. If we just step back for a moment and we look at how much funding has been cut, what the kind of changes have been that have been made over the last 10 months. Do you think that these are things that are very concerning because they're going in the wrong direction, but that there's still, world-class research in medicine and other fields going on in the United States today, that by and large, newborns are still continuing to get the same vaccines that they were a year ago? Or are we already at a time, at a place in which there's been such big changes that it has a very measurable impact on people? Let's start by saying within the United States, and then I want to get into obviously the cuts to USAID that I know you've been working on a lot in a moment.
Yeah. Okay, so we'll start in the U.S., but I do think it was significant that the pattern was set outside the country in populations that we didn't see as Americans here at home, but it's had devastating effects. When you extended many of those policies, for example, now towards starting to cut back cut confidence in vaccines, that you have seen the dismantling of HIV prevention programs at the CDC, when you have stopped all federal research funding to Harvard and a bunch of other universities, when we have stopped HIV vaccine research and development funded by the federal government. I can go down the list, but it's been devastating. it is devastating in a very particular way. As a case in point, our research training budgets have been slashed, and that has meant that we have dramatically reduced the number of PhD students, doctoral students out there being trained in science, and postdoctoral graduates who are then getting their early experiences in science. I've said before that this has suddenly become the worst time to be a young person who dreams of a career in science. People are, neuroscientists are driving Ubers, and the result of that is a sacrifice of our seed corn for what has made the U.S. one of the most important leading countries in advancing human lifespan and capability. This last century, we have been the country that has invested the most in the research, developed the leading population of science and clinical researchers. And that capacity now is seriously damaged. That's the first level of harm. The second is we've suddenly determined that major areas of really important work are sort of verboten. If they're not blocked entirely, they're severely damaged. HIV work has been research work, and prevention efforts and so on have been slashed severely. Work on the development of new vaccines, an entire platform of mRNA vaccine development, which would be critical to our readiness for any future pandemic, has been abandoned. And you can go on down the list, anything around dealing with racial disparities and then trying to understand what we can do to reduce a many-fold increase, higher rate of death in Black women who are pregnant. That's been slashed, and that is insanity in many respects and deeply harmful to our future. The translation into lives lost immediately is unclear. We are seeing now, for example, in Portland, Maine, or in Maine anyway, I'm not exactly sure where, an outbreak of 30 cases of HIV in a homeless population, and not having the CDC released to allow emergency support during the government shutdown. Those are ways in which this translates into genuine harm, and we're not prepared and don't have the systems in place for if we do face, major outbreaks spreading.
Let's go to the international side of this. You were assistant administrator of USAID. I feel like that's one of those agencies that people knew exists, knew was doing something, and probably suspected was doing something important, but probably couldn't have described very well in terms of what it actually does. Back a few years ago when you were assistant administrator of the agency, what did it do?
Yeah. So there's no question, my mom couldn't have described what I was doing either, right? USAID, it's in the name. You aid other countries to develop, and also it's our country's investment in a certain model of thinking. It was founded by JFK, taking the lessons of the Marshall Plan. The Marshall Plan was where we did this very unusual thing in history of coming out of a war, and instead of plundering the people for their riches, we invested in the countries we defeated. We brought a Marshall Plan to help them redevelop their economies, whether it was Germany, Japan, Italy, and so on. And it paid off spectacularly. We ended up fostering peace and stability. We also grew important trade partners for us in the world. It helped lift our own prosperity. And so John F. Kennedy founded USAID on the principle that we would do the same in other parts of the world. It was the agency that drove the eradication of smallpox around the world and ended a killer that had cost 500 million lives in the previous century. It was the agency that took countries like India, brought them food aid to get through famine and terrible humanitarian crises, but then also invested in building their expertise and agricultural strength so they'd become a food exporter and free of aid in the world. The translation of a largely low-income Latin America into becoming a middle and high-income Latin America for 80% of the countries was because of 20, 30 years of U.S. leadership and investment in supporting development instead of destroying development. So what USA did when I came in, I found a place where it was the best job in medicine that you have never heard of. I had 2,500 people in 65 countries. Our job was to deploy resources to reduce mortality and improve lifespan with as optimally as we could. The budget, out of a $15,000 American taxpayer payment in taxes per year, for every American, we pay about $15,000 each in taxes on average. $24 was what we received as a budget. It was amounted to less than half of my hospital's budget. And we deployed it in ways that reached hundreds of millions of people and saved lives by the millions. So that was HIV control, TB, malaria. It was maternal and child health, improvement in systems for getting better vaccination, addressing diarrheal illness, addressing deaths in childbirth. It was family planning. It was a variety of things around the biggest killers for human beings, both saving lives now and improving systems later. And that's what translated into the 90 million lives saved in the last 20 years. It's arguably, so there's a legitimate criticism that USAID could be more efficient. It could focus too much on international nonprofit organizations and not enough on building local organizations. That there was a dark history at times to USAID where its aid was used to pursue political and military aims in Vietnam and Iraq and Afghanistan. None of what happened was addressing any of those issues. In fact, USAID was the highest impact in lives saved of any agency per dollar in the U.S. government, and its dismantling was recognized. It was initially a pause that the president put in place on his first day in office, a pause on foreign assistance. Within weeks, it was apparent that hundreds of thousands of lives would be lost by the end of the year. And instead, they doubled down. They had no curiosity. It was the gleeful swinging of the chainsaw by Elon Musk. And they purged the staff, terminated 86% of the programs, and impounded the funds, and then shut the agency down. And the result is 600,000 lives lost so far, estimated, as of the beginning of November.
So 600,000 lives lost is a huge tragedy. It's also such a big number that it seems very abstract. Tell us about some of the direct impacts that had on people and how we can be sure. I'm sure that some estimates say 500,000, some estimates that say 700,000, but how can we be so sure that there really are a large number of lives that have been lost as a result?
Yeah, it can be hard to see, right? After the great leap forward of the late 1950s in China, it was 23 years before people actually got the mortality, the vital statistics released in China that showed 50 million people died. We currently are not, the aid cutoff has cut off measurement of many of these programs. They fired the inspectors general who would be auditing and showing where the damage is done. The UN mortality estimates won't be available for 2 years to tell us what happened in 2025. But there are several ways that we know. One way is there's researchers tracking based on what we know has happened when individual countries were cut off from aid. And we've seen the pattern of the mortality reductions. So they've made a Boston University mathematical modeler named Brooke Nichols has made estimates that are based on those kinds of studies and made very conservative assumptions. For example, that only 25% of the HIV funds that have been cut will be sustained as cuts through the end of the year. 75% would be restored. That hasn't even happened. That the impounded funds that remained would be released and sent around. And that number of 600,000 is based on a conservative estimate. 90 million lives saved is a well-documented description, and we know that translates over 20 years to many millions of lives from these programs, and so it's not inconceivable that this could be happening. But the other way that I pursued going and trying to find out what's really happening was by actually visiting the places that where the aid cuts had happened and seeing it for myself. A film crew followed me as I traveled. We made a short film, a 22-minute film that's been released by The New Yorker and is also on YouTube called Ravina's Choice. And one of the things I was particularly wanting to see was, I visited primary health centers, I visited an AIDS referral center, and here was a refugee hospital, settlement that along the border of Kenya, that was where they're surrounded by unstable countries like South Sudan and Somalia. And one of the things we'd been able to implement at USAID was findings that came out of U.S. research and research abroad, showing that you could cut the mortality rate of children with severe acute malnutrition from 20% when they arrive in hospital facilities to under 1%. That basically mortality did not need to happen by giving a therapeutic food, specially formulated peanut-based kind of peanut paste that could rescue the children. You could do it at home, and you, with community health workers simply having a measuring tape and a scale, could identify children before they got to the worst stages and do interventions cost effectively, train people in these systems, and make sure these basic approaches were deployed. And we brought significant parts of the world to get their mortality rates down below 1% for severe acute malnutrition. I wanted to see whether those systems, what was happening to those systems. I did a lot of work in Kenya as part of my work. And what I saw was the total breakdown in those systems. And the movie is simply following the experience of the people in the clinic where this was happening and the experience of a mother with a child who is sick and starving and trying to navigate a broken system to get the care that that child needs. And she's forced to make a terrible choice that no one should have to face. I'm not going to give it away. I implore people to go on to YouTube or the New Yorker website and see it. But you can now, it is not hard to envision how there are tens of thousands of people just from the malnutrition cutoff of training support systems alone that are in harm's way, let alone from the cutoff of vaccines, the cutoff of training and systems and other domains of global health.
I haven't yet seen the movie, and I look forward to doing so. I'm not sure that's the right term. It sounds harrowing, but important. Do you think that if there is a democratic administration in 2028, they're going to rebuild USAID? And if they do, should they rebuild it as it was, or are there changes that they should make? Is there a way to use this horrible suffering that resulted from this dismantling of USAID to build an institution that might transform even more lives positively when and if it is rebuilt?
I think there is action that is possible even sooner than that, right? If the Congress actually can pass a budget, the House and Senate, both institutions the Republicans have backed higher levels of foreign assistance and global health work in particular than has otherwise been provided by the administration. Now, it's an open question whether they can pass a budget. There's a lot of pessimism that they won't be able to, and then it just leaves it for Trump to do whatever he wants. And that I have no great hope that there is going to be a change there. But, even in a midterm, if there is any shift of power, the ability to move budgets forward that would refund not just USAID, but CDC, NIH. I mean, these are popular programs. These are not under attack except by this administration. And so that can change even sooner. Building a development agency, a development capacity, is a crucial part of what I think any administration will need to do coming in whoever follows Trump. Foreign policy rests on a three-legged stool, as people often say, of defense, diplomacy, and development. It's less costly. It is more effective in winning hearts and minds and building influence, as well as bettering humanity, to include development expertise and capacity. USAID was our largest civilian capacity, operational capacity around the world. And we've lost a footprint that had, more than 10,000 people around the world, but they had networks that reached hundreds of thousands, likely millions of people that we were able to deploy. One of the things I did, for example, was when Ukraine was invaded by Russia again, Russia cut off the supply of medicines to the country. It also bombed the oxygen factories. And, with a team of about 40 people, we were able to work with the Ukraine government, no military, and restore a system that could supply medicines from their western border, that could make sure 250,000 people with HIV and almost 1 million people with heart disease could get their medications that month, that and the casualties would have dwarfed anything that the bombs would have done. Got oxygen, getting back to supported the country to get oxygen back to the hospitals and things like that. So that capacity is already missed now and is going to be missed and needs to be rebuilt. It will not come back quickly. You can't dismantle that entire kind of network and build it right back in the space of months. This will take years, but we will absolutely be rebuilding that. It's in our interest as a country, and it's too stupid to not address the issue.